All right, hi everyone. We're going to go ahead and get started. I'm Julie Spohn. I'm the Criminal Justice Behavioral Health Program Coordinator for the Ohio Department of Mental Health and Addiction Services, and I oversee the Addiction Treatment Program. Thank you for taking the time to attend the webinar this morning to learn more about the ATP. With me, I have our Criminal Justice Bureau Chief, Chris Nicastro, and our Deputy Director of Treatment and Recovery, Jody Lynch. And then we have the Department of Medicaid here. And with us is Kara Miller, Tracy Hayes, Michelle Barger, Liz Mutters, and Mary Holler. So both counties that are participating in the ATP and additional expansion counties have been invited to attend this webinar. So I'll be providing a complete overview of the ATP and also reviewing some fiscal year 18 updates and changes. The Department of Medicaid will also be sharing some updates on their end, and I will open it up to everyone to ask questions at the very end. Thank you. To ask a question, please type into the text box located in the lower right-hand panel. All webinar participants are set to mute, so therefore, if you verbally ask a question, we will not be able to hear you. If we run out of time, we'll be able to review all of the questions and follow up with responses afterwards. So please go ahead and put your question in that chat box in the right corner. And then there's also some handouts that are attached to the webinar, and you can view those in the handout section in your panel right above the chat button. And we will also be posting a recording of the webinar and presentation materials on the ATP webpage, which can be accessed by going to mha.ohio.gov, selecting treatment in the upper left-hand corner, and scrolling down to criminal justice and selecting addiction treatment program. So first, I'll start by giving an overview of what the addiction treatment program is. Ohio Mass was given authority and funding to continue the ATP to expand to additional counties throughout fiscal year 18 and 19. The ATP funds treatment and recovery supports for eligible clients that are enrolled in select drug and family dependency course. The funds can be used to cover medication-assisted treatment, which includes FDA-approved long-acting antagonist therapy, partial agonist therapy, or full agonist therapy. Note that this is a change from previous requirements, which did not fund clients receiving full agonist therapy, also known as methadone. The funds may also be used to cover other treatment services, treatment for co-occurring mental health disorders, as well as time-limited recovery supports. This slide reflects the counties that have been selected to participate in the addiction treatment program. Counties are separated by fiscal year that they began participating in the ATP. The ATP started as a pilot program known as the ATPP in 7 counties in fiscal year 2014 and 2015. Case Western completed the evaluation of the pilot program, and a report of their evaluation can be found on the ATP webpage. In fiscal year 2016, Ohio Mass was awarded funding to continue the program, and we implemented the ATP into 13 counties throughout Ohio. In 2017, Ohio Mass was able to expand the program to an additional 9 counties, serving a total of 22 counties. The Treatment Research Institute was selected to complete an evaluation of the program throughout fiscal year 16 and 17. In this fiscal year, we are given additional funding and ability to expand to another 9 counties. So there are 3 eligibility requirements to participate in the ATP. The client must be enrolled in one of the selected Supreme Court certified MAT drug or family dependency courts. The client must have an opioid and/or alcohol addiction, and the client must be deemed eligible for MAT. Clients that are eligible for MAT may choose not to utilize MAT and can still participate in the program. Ohio Mass was awarded a total of $16 million for fiscal year 18 and 19, totaling to $8 million per fiscal year. So funds are processed as an allocation and distributed on a quarterly basis through GFMS to the county Adams boards. The funds flow through the Adams boards to the participating ATP providers. Funds may be used for treatment and recovery supports for ATP clients as clinically appropriate. Last year, we limited the usage of funding for by client, so it was $2,000 per client. And when the ATP first rolled out, counties were given a certain number of funding slots that they could use. So this year we've done away with all of that. There's no slots, there's no funding amount per client. Funds should just be used as clinically appropriate for each client. The hope is that this will eliminate barriers and confusion related to funding usage. Treatment providers may contract with outside agencies to fund services that a client needs but that they do not offer. So for instance, if a client would benefit from peer recovery support, but the ATP provider doesn't offer that service, the provider can contract out with an agency that does offer peer recovery support and cover the cost of that service. This next slide covers recovery supports, which may be funded through the ATP. Recovery supports are defined as assistance that is intended to help an individual with addiction or mental health needs to initiate and sustain recovery. These services are typically not covered by insurance. Providers and courts should identify recovery support needs on an individual basis based upon clinical judgment and client needs. Some examples of recovery supports include housing such as recovery housing and short-term housing, transportation services such as bus passes, gas cards, and cab or Uber fares, identification such as driver's license, social security card, or birth certificate, employment services such as job training and uniform, emergency basic need items such as food vouchers, clothing vouchers, and hygiene products, and peer recovery support services, support groups, and relapse prevention services. And like I said, those are just some examples of how the funds could be used. So the legislative language now enables us to fund administrative costs for courts. This is a change from last fiscal year. And I have sent out administrative funding allocation amounts by docket to each Adams board. The board will then pass the specified amount to each docket. Administrative funds will account for 5% of fiscal year 18 funds, which amounts to $400,000. And the funds were split up between dockets based upon program participation rates. While the funds may be utilized at the court's discretion, the funds are intended to assist courts in serving more clients and covering staff time for collaboration with other agencies involved in the ATP and data entry and other responsibilities related to serving ATP clients. So I wanted to review a typical process of how things should flow for clients that are eligible for the ATP. But please note that I do understand that each board, court, and treatment provider operates a bit differently and may develop different processes that work best for them. The court should be identifying those who are eligible for the ATP as new clients enter the docket. But note that if you are now just implementing the program into your docket, you will likely have clients that are already active in the court that are eligible. However, once you're further into the program, clients would hopefully be identified when they first enter so that they can start utilizing the funds as soon as possible. Court staff would then have the eligible client sign a release of information, which would include the Ohio Department of Mental Health and Addiction Services, the Ohio Department of Medicaid, the ATP treatment provider, and the research institution that is selected to complete the evaluation. At this time, we are still in the process of selecting the research institution. Therefore, you would not need to include that entity quite yet. The specialized docket staff will then refer the client to one of the treatment providers selected to participate in the ATP. Note that other agencies that are not ATP providers will not have access to the funds. Therefore, it makes the most sense to be selecting providers that are most widely utilized among the courts. When referring the client for treatment, it is important that court staff inform the provider that the client is eligible for the ATP so that they know that they can go ahead and use the funds for that client. I have found that this process typically works best when there is open communication between the courts and the providers. Counties in which courts are working with providers to help identify clients' recovery support needs seem to maximize the use of the funds and are able to better link clients with services that will assist their recovery. Once the client is linked with the ATP treatment provider, the provider will then determine the insurance status of the client. If the client is uninsured, the treatment provider should be assisting the client in applying for Medicaid. ATP funds can cover treatment services until the client is enrolled in an insurance plan. If the client is already enrolled in Medicaid, or once an uninsured client becomes enrolled in Medicaid, The provider will then need to complete the MAT communication form and submit it to the client's managed care plan. The Department of Medicaid will be speaking a bit more to this form, how to complete it, and the purpose of it shortly, so I won't go into further detail about that process. Lastly, if the client is enrolled in private insurance, ATP funds may cover copays for treatment. The ATP provider will then begin to identify treatment and recovery support needs of the ATP client and may utilize the ATP funds to cover the cost of those services. Note that, as I mentioned previously, ATP providers may refer the client for additional support services not offered within their agency. They will then contract with the outside agency to fund the services rendered with ATP dollars. So the legislative language requires the completion of another evaluation of the ATP. Currently, our department is still in the process of selecting a research institution and will then coordinate logistics with the selected institution. Data entry related to client compliance, attendance for services, outcomes, and services provided will be required by both the participating treatment providers and specialized dockets. Since we have not yet selected a research institution, I do not have further details related to the evaluation at this time. However, we will update you as we move forward in this process. This slide discusses quarterly reports for the ATP, which I sent out to each Adams board this week. The reports are to be submitted quarterly via email by the Adams board and are due at the end of the following month after each quarter. Note that this is a new requirement that we did not have last year. The reporting will include the total number of clients served by each docket from the start of this fiscal year through fiscal year 2019. The reporting also includes the amount of funds used throughout each quarter, categorized by treatment service and recovery support services. This information will enable our department to better provide programmatic oversight, address any barriers to spending and funding and funds by county, and also provide us with information to make informed budgeting decisions in the future. I just wanted to take a moment to review all of the programmatic changes for this fiscal year. I have mentioned all of these already throughout the presentation, but I wanted to highlight them for the counties that are currently participating in the ATP. First off, we are expanding to an additional 9 counties, so we will now have a total of 31 ATP counties. Secondly, we are now able to provide funding to specialized dockets for administrative costs of the ATP. The funds will be passed from the Adams board to the dockets. Previously, the legislative language stated that only long-acting antagonist therapy or partial agonist therapy may be used. The language now includes full agonist therapy, and therefore clients receiving methadone may now participate. We are doing away with the $2,000 limit per client, as originally referred to as the slot system. Funds may be utilized based upon client needs. Treatment and more urgent recovery support needs should be prioritized if available funds become limited. Lastly, participating dockets may now receive funds to cover administrative expenses. The funds will be passed from the Adams board to the, I said that already. Yeah, so courts can receive administrative expenses, as I said. So I wanted to take a moment to briefly summarize the responsibilities of each party. Participating dockets should be selecting clients to participate in the ATP based upon the eligibility requirements, having eligible participants sign a release of information, sharing the release among other relevant documents to the provider, and providing relevant updates regarding the client status to the treatment provider. Dockets are also responsible for collecting and reporting data as it relates to the requirements of the evaluation. Participating treatment providers must be certified by the Ohio Department of Mental Health and Addiction Services. They're responsible for utilizing an integrated service delivery model, conducting comprehensive diagnostic assessments, determining treatment needs, and developing treatment plans accordingly. Treatment providers should be providing clients access to MAT, other therapies for substance use disorders and any co-occurring disorders, and access to time-limited recovery supports. Providers should also be monitoring compliance through collaboration with the drug courts, completing the MAT communication form for Medicaid recipients, and assisting clients in applying for Medicaid. Along with the dockets, treatment providers are also responsible for entering and collecting data for the purpose of the evaluation. Adams boards are responsible for drawing down the funds and passing them to the treatment providers to cover the cost of recovery supports and treatment services. They will also be expected to pass a specified amount of funds to each participating specialized docket to fund administrative costs. The Adams board will also need to complete and submit the ATP quarterly report. Some of the shared responsibilities are that courts and boards should be working together to identify ATP treatment providers to participate in the program, and a process should be identified for referring appropriate individuals to participate in the program so that treatment providers are aware that they are able to bill the ATP for services rendered. Communication about client needs is also helpful to ensure that available funds are able to be used to best support participant needs. And as always, appropriate releases of information and consent forms should be utilized in order to exchange information and maintain HIPAA compliance. In collaboration between the board, providers, and courts will help this program run smoothly and tends to help counties maximize the use of the funds to best serve eligible clients. I also understand that each county operates a bit differently and will have different processes to run the program in a way that most efficiently suits their setup. I wanted to make note of some ATP documents that may be useful for you to reference. So the Addiction Treatment Program Guide is a document that provides an overview of the process of the ATP, the eligibility criteria, and a summary of fiscal year 18 programmatic changes. And that document is attached as a handout among most of the other ones on here, as well as if they're not already on the ATP webpage, they will be added this week or within the next week or so. The Recovery Supports and Treatment Services Guide is another informational document that provides examples and categories of recovery supports and treatment services that the ATP funds can be utilized for. The MAT communication form is to be completed by treatment providers for Medicaid recipients enrolled in the ATP. The ATP quarterly report is to be completed and submitted by the Adams Board each quarter. And the Memorandum of Understanding will be distributed for participating agencies' review and signature. And those have been sent out to each Adams Board to collect those signatures of the treatment providers and specialized dockets that are participating. And I will now turn over the presentation to Tracy Hayes, who is going to go over the MAT communication form, and then Kara Miller from the Ohio Department of Medicaid will also be presenting on Medicaid.
Good morning. I'm going to briefly discuss three handouts that will be available. These are related to the communication for Medicaid recipients so that the managed care plans are aware which of their members is participating in the ATP. The first is in a letter format, and it's the instruction page for the actual communication form. It has instructions for verifying Medicaid eligibility either through our provider portal or through the interactive voice response system. The web link and telephone numbers are provided on the instruction form, and then explains the purpose of the form and the sections that would need to be completed and under which circumstances. We've simplified the form quite a bit, so there are only two very brief sections for completion. The first section is demographic information, member name, date of birth, address, prescriber, the 12-digit Medicaid ID if known, and the treatment, the MAT format that the individual is receiving, so Vivitrol, buprenorphine, methadone, or none. On each form, there is a payer name and contact information chart, which lists the 5 Medicaid managed care plans and also our Medicaid fee-for-service departments with their member services, their ATP fax number and email, communication for care management referrals for secure email. And we have developed a form in 2 formats. One is the sort of low-tech format if you're used to printing and keeping paper copies of forms available in your office to manually fill out, scan, and fax. Or if you do a virtual forms or desktop form, we do have a fillable format available with interactive fields to click and type in order to fax from the computer or send via secure email.
Thank you, Tracy. Good morning. This is Kara Miller. I'm with the Ohio Department of Medicaid, and I just wanted to spend a few minutes to go over some reminder points about Medicaid that might be useful to the courts, the boards, and the treatment providers. I understand that one of the responsibilities for treatment providers is to assist consumers or those who are uninsured in applying for Medicaid, and so we wanted to provide 3 different ways that that consumers can be connected to the Medicaid application process. There's the online benefits.ohio.gov where an account can be set up, an individual can apply for public benefits, and then also track his or her application. Applications can be taken through the Medicaid hotline, the toll-free number is listed here, as well as through the local county Department of Job and Family Services, whether in person, mail, or fax. What happens after Medicaid is approved? Many residents in Ohio who are eligible for Medicaid must receive their benefits through a managed care plan. In fact, 86% of Ohio Medicaid recipients are receiving their benefits through one of our contracted managed care plans. So consumers are given a choice of one of 5 managed care plans that are available statewide. If no choice is made, then there is an assignment to a managed care plan, and a consumer is able to change plans within the first 90 days of enrollment, and then at open enrollment in November of each year. So right after Medicaid is approved, there is this brief Medicaid fee-for-service span, usually about 30 days before the managed care enrollment takes effect. The effective date of enrollment, whether it's initial or change, is always the first calendar day of the month. As Tracy mentioned when she was reviewing the communication form, we just wanted to recommend that treatment providers are verifying Medicaid eligibility and also the payer on a monthly basis. And so here are the 3 ways that providers can verify Medicaid eligibility. What do providers, courts, and boards need to know about the difference between Medicaid fee-for-service and managed care? Medicaid fee-for-service are where providers are delivering services to consumers and then bill Medicaid directly for those services. We have a very small segment of our population who are covered in the traditional fee-for-service system, as I already stated. Most of the recipients are receiving their care through a contracted health plan, which is a health insurance company that works with their network of providers to coordinate care and facilitate access to services. All 5 plans that we have contracts with are listed here. They're available statewide: Buckeye, CareSource, Molina, Paramount, and United. Here's a quick review of some of the benefits of managed care. Most of these value adds that are listed here are really from the member perspective, but there are a few listed here for providers as well. There's a dedicated contact through a provider services line. The plans work to assure expanded access to care by linking with primary care, providing assistance with finding providers and scheduling appointments, and arranging transportation if needed. Care management is another one of these benefits that actually, in completing the communication form that Tracy spoke about, this is one of the critical benefits that allows for access to be opened up to. So if you're working with a drug court participant and you're finding that you're running into barriers to care or needing assistance with addressing some of the social determinants of health around housing or financial assistance, there's contact information on the communication form that you can request assistance in the care management space. Plans also offer enhanced benefits and health and wellness programs. Just a quick review of what Ohio Medicaid covers. Our base benefit package, behavioral health services are listed right here at the top since it's most relevant to this audience. And then there's preventative services, prescription medications, inpatient hospital services, emergency services, DME, doctor visits, and many more. And we just noted here at the bottom that the managed care plans are also required to cover all Medicaid covered services. Some of them may require prior authorization and may have limits on some of the services. And this is actually one of the most important slides in the Medicaid portion of the presentation. And so as many of the treatment providers are aware, there are changes underway right now to the Medicaid behavioral health benefit package that go into effect on January 1st, 2018 for the community providers, the 84s and 95s. As well, the services will be carved into the managed care benefit package, also effective January 1st, 2018. So while we're in this period of transition, we just wanted to be very clear about what entity is paying for which behavioral health services. And so you'll see in the second column, which is listed present day through December 31st of this year, whether it's for someone who is enrolled in Medicaid fee-for-service or in a managed care plan. Any Medicaid covered addiction, treatment, or mental health services are billed by providers to Medicaid fee-for-service, and also the methadone initiation and maintenance is also billed to Medicaid fee-for-service. What managed care will pay for is any Medicaid covered prescription drugs prescribed by an MHAS certified provider that are filled at a plan's contracted pharmacy. Plans will also pay for generic buprenorphine and then Vivitrol, which is provided by an MHAS certified provider. And then lastly, any Medicaid covered lab services like the urine drug screens, if they're referred out by a provider, the plan will pay for it if it's referred out to one of their contracted labs. And then beginning January 1st, 2018 going forward, all of these services will be covered by managed care plans, so there's no need to then split the billing in this way. And then we just want to note that the new behavioral health benefit package is in effect today only for outpatient hospital facilities that have accreditation for behavioral health services. And if you would like more information about behavioral health redesign, I included the link here. So this is a key slide or resource for the providers that are participating. And I will turn it back over to Julie. Thank you.
So this slide just notes all of our program partners. So I just wanted to take a moment to note that, you know, we worked with the Ohio Department of Medicaid, the Supreme Court, and then we've worked with you guys, the Adams Boards, the MAT drug courts, the treatment providers, and the Medicaid managed care plan. So I appreciate everybody working together to make this program possible. So now we're going to move on to questions and answers. I did want to note that the ATP point of contact, which is Chris Nicastro. I will be switching to a new position come Monday, so Chris will be your main contact until there's a replacement for me. And then I also put the ATP webpage. There's a link, or you can go to our website, and there's directions on how to actually get to the ATP page. So go ahead and type your questions, as I said, in that chat box. We won't be able to hear you because it is muted. We didn't want to have people talking over each other. So if you type your questions there, we'll be able to read them off and answer them. Okay, so our first question, all drug court clients qualify for ATP, or only the ones who enter the drug court system after 2016? So anybody that's enrolled in the specialized dockets that meet the eligibility requirements may participate in the ATP. I believe this question is referring to back when we first rolled out the ATP in 2016, and because the evaluation was just starting, we were only able to have new clients that were first entering the drug court. Anybody that meets the eligibility requirements may participate regardless of when they entered the drug court. Are providers supposed to use or submit the quarterly report instead of the monthly one? So quarterly reports are submitted by the Adams Board, and I know last year's expansion counties, they were directed to send monthly reports to me. So this is a change. We're doing away with those monthly reports. Treatment providers won't be sending any reports directly to me. However, there will likely need to be coordination between the Adams Board and the treatment provider, as well as the specialized docket, so that the Adams Board can collect that information to put into the quarterly report. So treatment providers will need to send their funding information to the Adams Board, and specialized dockets will need to send the number of clients that are participating to the Adams Board. Are the 9 additional counties now active with the ATP program, and if so, have the participating behavioral health agencies been identified? So we've been working with the 9 additional counties to get them acclimated to the program. This webinar was really a rollout of the whole overview of the ATP for them. So none of them have actually started. We have submitted funding allocations to fiscal, so if they haven't gotten those yet, they should be getting them soon and are able to start rolling with that once they feel acclimated to the program and ready. Most of the behavioral health agencies have been identified. There's some follow-up needed with some of the expansion counties to make sure that all of the agencies that they would like to include have been identified. So for the most part, yes, but still working on that a little bit.
Can I add one? So this is Kara from Medicaid. So when the BH agencies for those counties have been identified, we'll be sure to share them with the managed care plan.
Yes, yes. Are there any stipulation around the administrative funds for the courts? So the funds can be used at the court's discretion. We're not tracking what they're using those funds for. The purpose of the funds, as I had mentioned, are to cover those administrative costs and staff time put into the ATP, but no, they can be used at the court's discretion. Are we able to bill for methadone client services for July? Yes, you can bill for methadone client services for July. As a court staff, when we see that a client needs recovery supports, can we ask treatment providers to provide it and use ATP funds for it? Such clients need bus passes. So yes, if you identify a client that needs recovery supports, you can work with your treatment provider, with that client's treatment provider, to say, hey, I see this is a huge need for this client. They don't have any transportation. I'd really like to be able to get them bus passes. Can we go ahead and use those ATP funds to get that? And it's at the discretion of the treatment provider to determine what's clinically appropriate for that client. But yes, this program really runs the best when the courts are working closely with the providers so that we're ensuring that all of the client's recovery needs are met.
And I would also say that this would be an opportunity for the providers and the courts to partner with managed care plans who also provide transportation assistance to get to appointments.
At what specific point in the referral process from the docket to the provider agency does a client become eligible to receive funding? So the client will come into the specialized docket, and once they're active and meet all those eligibility requirements that I had mentioned, those 3, that they're active in the docket, they have an opioid and/or alcohol addiction, and they're deemed eligible for MAT, they can start to utilize the funds. So once they're assessed by a physician and are deemed, in fact, eligible for MAT, they can start to use those funds. Butler County has a SAMI court. Would those clients be eligible? Unfortunately, the ATP only covers specialized drug dockets and family dependency dockets. So any other courts, although we recognize that they serve clients with similar issues and that would meet eligibility criteria, otherwise we can only serve those clients, and that's due to the legislative language that states that it's only clients in the drug courts and the family dependency dockets. Can additional agencies in existing and expansion counties apply somehow? So no. The way we chose our agencies, or the way we chose the dockets, were based upon an RFI that was given to the boards and was also sent out to each specialized docket, at least the drug dockets and the family dependency dockets received a copy of the RFI to work with their Adams board to submit their information. So if you are an eligible docket that was somehow missed, you can work with your Adams board and contact me or Chris, and we can see. But I believe that we went through and I went through and looked at all the dockets that potentially could be eligible and discussed with each Adams board if there was anybody that wasn't included in the RFI to make sure that we weren't missing a docket. In regards to treatment providers, I'm not sure which type of agency this was directed towards, but the Adams boards were asked to work with their specialized docket to select their treatment providers. So that's how they are selected. So we're not actually applying for the ATP. And the participating counties were selected via the legislative language that chose the 9 expansion counties. Can administrative funds cover treatment providers' time spent in team meetings and status hearings? So the administrative funds are only for the specialized dockets, and the reason being is that the legislative language states that administrative funds can be given to the specialized dockets. So we're unfortunately unable to give treatment providers administrative funds at this time. Can ATP funds be used to pay reinstatement fees for driver's license? The funds can be used, that can be considered a recovery support. The funds can be used for recovery supports as clinically appropriate to each client. Can I please have an electronic copy of the slides? Yeah, the slides are actually attached as a handout in the handout section. They will also be posted on the ATP webpage. Do we push out the administrative dollars to the courts in one lump sum from the first quarter distribution? So that can be determined by whatever the Adams board prefers, whether you can give it to them as one lump sum, or you can do it quarterly, just like we allocate the funds quarterly. Do you have an example of the MAT communication form the audience can view? So there's actually, if you go to our ATP webpage, there is currently an MAT form posted there. It is not, note that it's not the most updated one. We just got it updated this morning with all of the correct context, but for the most part, the look of it will be similar. But we will be posting that on the ATP webpage, and I will also send it out to everybody. Do you provide the release of information template for us to use? So no, each specialized docket and treatment provider should be using their own releases of information. Does the administrative cost also include curriculum? So as I mentioned, the administrative cost is just for the specialized dockets, and they're able to use that at their own discretion. For the quarterly report, can we estimate the charges? With some, if not most of the clients getting Medicaid at some point within treatment, it is not always known after 30 days how the treatment services are paid. Waiting on Medicaid, pay with ATP, find out Medicaid retroactively paid the treatment. So board now has to credit ATP. All of that said, the October report may not have all the September information, but could have an estimate based on services provided. So for that question, there are some good points in that question and something that we want to discuss internally. So we do have the questions here, and we'll save that note to get back to you. And I also can see who asked the question, so I'll go ahead and respond to that person. Somebody asked, how do you document Uber to utilize it? So I think what you're asking is, how do you want to use the funds to fund an Uber, but how do you document it? On our end, we're not collecting specific information about a specific service that was billed for the ATP. So really, you just need to track how much of the funds you're using for recovery supports and how much of the funds you're using for treatment. Someone said they're not able to download the handouts. Will they be emailed to the attendees? I should be able to go in and pull everyone's email and send that out through the webinar. If not, so I will attempt to do that this afternoon. If not, they will be posted on the ATP webpage as well. I thought I heard that the Adams board will have to draw down the funds quarterly. I went on to GFMS, and ATP is in as an allocation and not an application. Ohio Mass sends out the applications quarterly automatically. Do we need to put ATP in as an application? So no, the funds do come through as an allocation. You're correct. I understand that effective January 1st, CareSource will no longer cover your analysis, correct?
This is Tracy Hayes. I'm actually the contract administrator for the CareSource Managed Care and My Care program. They are not covering UDS for non-participating providers, so you'll have to utilize their panels, laboratories, for urine drug screening, but they are still covering the service. It's just that they have limited to non-panel or limited non-panel access. Put it on mute for a second.
And we're going to go ahead and follow up to that your analysis question, because we want to look at some details of that as well to make sure that we're giving everybody accurate information. I understand that there is no longer a $2,000 limit per client. In the past, was this $2,000 limit a monthly limit? How are funding formulas determined now for counties? So in the past, each client was able to utilize $2,000 per month, and funds were able to flow between clients. So if a client used $1,000 and another client needed $3,000, you could do that. Now we just did away with that because we found that it was just a barrier to using the funds. So now the funds can be used by client need. So we expect that if a client's uninsured, they're probably going to use the bulk of the funds for treatment. But if a client is insured, they can still use those funds for recovery support. The funds should just be used as clinically appropriate to each client's needs. And if funds are limited, treatment services should be prioritized along with any urgent recovery support needs. If boards hold the administrative funding, how do we pay that to the court? Will the court invoice the board? So the board should be passing the funds to the court just as they do for the treatment providers. But for the courts, it's just the funding amounts that we specify. If somebody is already on MAT with a provider but new to the family drug court, is the drug court still the entity that refers and identifies them, or can the provider do that as well? So when a client comes into the drug court, prior to being in the court, they weren't eligible for the ATP because they weren't enrolled in the court. So when they enter that court, the court should still be identifying them as an eligible client and working with the ATP treatment provider to ensure that they are aware that they can use the funds for that client. Is there a sample release of information? So as I mentioned, drug dockets and treatment providers can use their own releases of information. We're not sending out a standardized one. Is detox and residential treatment covered? So those services can be covered. As I mentioned, funding amounts should be prioritized as to clinical needs. So if you're running out of funds and finding that you're utilizing your funds on the bulk of your funds on a limited number of clients that are in residential treatment, you know, just looking at how to prioritize those funds to meet the bulk of the client's needs rather than focusing the bulk of them on residential treatment, if that makes sense.
So this is Mary Haller, and I wanted to just answer from a Medicaid perspective. Both detox services at various levels of care and residential treatment are part of the new behavioral health benefit package that's going to be implemented January 1. So detox is a service that runs across several of the ASAM levels of care and will be a covered service in all those levels of care. And then we will be paying for SUD residential treatment to certain residential providers as a part of the Medicaid benefit package. So for more specific information about that, you can go to the bh.medicaid.ohio.gov website that Kara included at the end of her slide presentation, and you can see there the full provider manual that goes through all the services, the codes, the rates, the modifiers, etc. You can also see a very large Excel spreadsheet that is a workbook that includes all of the coding and rates and provider types for the new benefit package. So, and there also are several educational presentations that we have done on the new BH benefit package that are posted on that website. The most current one is our level 401 training that was done back in May. So if you have any other questions about that, you know, feel free to reach out to me at the Department of Medicaid, Mary Haller. Thanks.
Is there a timeline in which the CMHCs have to notify managed care of a member's participation in ATP?
So no, this is Kara from Medicaid. There is no required time frame. It's just the sooner that the form is completed and sent to the plan, then the plan is aware of which of their members is participating in drug courts and might need the extra services and supports that a plan can offer. The only time there might need to be like a quicker submission timeline is when a drug court participant is taking or needs to take buprenorphine as the MAT, because for non-drug court participants, the plans may require prior authorization. So the use of this form actually helps to expedite access to that MAT or form of MAT.
Is there an identified percentage for administrative costs for either the Adams Board or the dockets? So we did a 5% of the total funding amount that we received from the state, and so that was $400,000. Then we did a percentage based on the number of clients expected to serve by each specialized docket. So there isn't a specific percentage that I can give you that each docket got because it was specified to the participation rates. And in addition, just specialized dockets are receiving administrative costs. This is due to the legislative language states that we can fund the specialized dockets for their administrative expenses. Once a facility is found for data entry, would we have to backdate all our data and enter it all? So I believe this question is referring to when the evaluation is rolled out, and currently we are still in the process of selecting a research institution, so we'll be able to better answer that question once the research institution is selected and all the logistics for the evaluation are determined. So does this mean that MAT services provided by treatment centers will go through managed care plans in 2018?
Yes. So once the behavioral health carve-in goes into effect, 1/1/18, those services will be billed to managed care plans.
So to clarify, the official date for the ATP would be after the physician assessment, not the drug court start date. So if the client is deemed eligible for MAT, I think that's what you're referring to. The client, goes to the physician and they determine if they're eligible for MAT. That makes them eligible, but the start date can be back when they enter the court because they were eligible back then. So if you need to backfill or something like that, if that's what you're asking, you can do so. Someone has private insurance. ATP funds can assist with copays for treatment. However, funds be used for deductibles? Yes, the funds can be used for deductibles as well. There are 3 qualified courts in our county. We receive the allocations along with administrative funds to the individual courts. However, the remaining dollars are for treatment, but are there limits of which court can use the treatment dollars? Is it based on the percentage of total? So the funds, so we gave all the boards a total allocation, and then I sent out specified amounts for each specialized docket. So that those specified amounts should be sent to each docket, and then the remaining funds from that total allocation can be used for treatment and recovery supports. So the board would then pass those funds to the treatment provider so that they can start to use those funds for treatment and recovery supports. I'm not sure if I fully understand the question. So if you asked that question and you didn't get the answer that you were looking for, please feel free to submit another question that helps clarify. We are a rural community and have very limited means of transportation. Would we be able to purchase a vehicle for employees to use to transport the clients? No, you're not able to purchase a vehicle with the funds. However, your staff can, if they're able or willing to use their own vehicles, they can bill for transportation that way, but they can't actually purchase a vehicle with the funds.
Yes, and again, this would be an opportunity for the treatment providers to collaborate with the managed care plans for drug court participants who have transportation needs.
We have multiple treatment providers within our drug court, but only one in ATP. What is the easiest way to reach the clients active in our docket, but not with the ATP provider? So I would recommend contacting me or come Monday, Chris, to let us know if you want to add some more treatment providers so that they can access the ATP funds as well. That would be the best way for them to directly use the funds. If you're just using that one treatment provider and a client's receiving services from another provider as well for a service maybe that provider doesn't offer, the ATP treatment provider can contract out with that other provider to allow them access to the funds and get all of their needs met. But otherwise, I would suggest adding some treatment providers as appropriate to what works well with your court and your board. To be sure I understand your answer, could you clarify if the Adams boards are able to claim administrative costs or just the dockets? So no, the administrative costs are just for the specialized dockets. We have noticed a pattern of the MCO denying or long delays in prior authorization for MAT medications. This has created a delay in client starting MAT.
So to respond to this particular question, the legislation actually mandates that Medicaid fee-for-service or plans are not allowed or permitted to prior authorize any form of MAT that is permitted under this program. So the plans will not be prior authorizing the buprenorphine or Vivitrol, and then during this 4-month transition while Medicaid fee-for-service is responsible for the methadone, there's no prior authorization for that either. If there are concerns with timeliness in accessing services, whether it's MAT or other needed services, again, that's where that point of contact on the communication form will be critical and will be a good resource for you.
What are the specialty dockets included in the ATP funding? I'm not quite sure I understand this question. The specialty dockets will, as I mentioned, get funds for administrative costs, and then in regards to any other funding, the funding goes to the treatment providers. The clients within those specialty dockets that are participating may use those funds for treatment and recovery supports. What is the amount to the courts? So the Adams boards were all sent specified amounts by court, which was based upon participation rate. So if you are unsure, if you are working in a specialized docket and unsure how much your docket received, you may reach out to your Adams board and ask them what that specified amount is, but it does vary by docket. What is the web address for the ATP site? So it's on that last slide. You can also go to mha.ohio.gov, select treatment, and then select criminal justice involvement and select addiction treatment program. What should we be tracking for data entry from now until the new research entity starts? So as I mentioned, that quarterly report, which is being collected by the Adams board, will collect data on the number of clients served by docket and the amount of funds used. So specialized dockets should have a roster of how many clients they're serving so that they can share that information with the board. And this should be now and continued when the evaluation starts as well. And then also treatment providers should be tracking how much funds are used so that they can share that information with the board. And they should be categorizing it by treatment and recovery support services so that the board is able to report that in the quarterly reports. When and how do we begin enrolling new clients? So a client comes into the specialized docket and you identify that they have an opioid and or alcohol addiction, so you say, oh, this client might be eligible for the ATP. And then they're seen by a physician, and the physician deems them eligible for MAT. So that client is eligible for the ATP. Currently, since the evaluation hasn't started, there's really no, place to enter them. You just, keep them on a list of clients that are seen for the ATP, communicating with the treatment provider that this client is ATP eligible. So there's no actual, database where you enroll a client or anything like that, just communicating with the treatment provider. And then once the evaluation rolls out, you would obviously enter that client into the database. When is the official start date for the enrollee in the ATP program? Is it the start of the drug court date or later? When the client comes in, whenever the client becomes eligible, so when the client comes into the drug court and they are deemed eligible, they can start participating. If a client's not seen by a physician right away, but then they're deemed eligible for MAT, you can backdate that start date from when they entered the drug court. When treatment providers contract with outside entities for services not offered, can this be outside of the ATP county? Yeah, so when treatment providers contract with outside entities that aren't in the county, that's perfectly fine. You can go ahead and do that. Will data entry still be done through the TriSet page? So as I mentioned, we're still in the process of selecting a research institution and not sure if which institution we'll be using. So the database will be based upon which research institution is selected, and we'll be able to share that information at a later date. Will the department maintain a running frequently asked questions list? Yeah, we can do that. Will these funds also cover room and board? So the funds can be used as a recovery support for housing. So yes, that ultimately it could be. With administrative funds based on participation rates, is there a minimum and maximum amount given? So the amount given was based upon a specified amount that was sent to the Adams board, and that'll be the amount for each docket for this fiscal year. Would it pay for drug screens given at Children's Services? So drug screens that are given at Children's Services can be covered. However, the ATP treatment provider would have to contract with the with Children's Services to get those funded. And that was all of the questions. So it looks like we just went 4 minutes over. I'd say we did pretty good. So I want to thank you guys all so much for taking the time to attend the webinar. If before the end of this week you have any questions, feel free to contact me. If not, please contact Chris. His contact information is on the last slide.